Okay, Tasha, I have started recording.
Fabulous, thank you. So I think Vincent Kersey has teed you up first. We'll be hearing about the live MDT sheet from you. Are you also brilliant? There we go.
Yeah, good to go. Wonderful. Hello, my name is Vincent. I'm one of the senior charge nurses here in urgent care, currently on ward J27. When this test of change was done, I was also managing the Hobbs unit as well. And the test of change has now since been rolled out to the whole of urgent care in terms of inpatient units, which is only the 3 units, 27, 28 and Hobbs. In terms of the problem and challenge that we had and that we wanted to implement the test of change, we had a great deal of duplication of information. So in terms of the MDT that we had prior to the test of change, this will probably be familiar to many of you on the call, but we had our nurse in charge attend the MDT with a nice sheet of paper with beds 1 through 30 written on that sheet of paper. They would then write down the updates, for example, bed 1, IV antibiotics, then they need some bloods taken tomorrow, bed 2 needs physiotherapy, and then they can go home, etc., etc. They would then exit that meeting, pick up the phone and phone someone like Mashid and her team over in the patient flow coordinator office, the bed managers in terms of terminology, and they would update all those bed managers with every single patient going from bed 1 through to bed 30. They'd then crack on with their day a little bit, and then an hour or two later, the matron would trundle along, and they'd ask them for that same information again, and they would deliver that same information once more from a verbal point of view. So the slide's quite wordy, but in terms of what was happening, we were having a great deal of duplication of information, which was leading to a wastage of nursing time, and that was duplicated across the nurse in charge, the matron, and the patient flow coordinator. This vehicle of information was kind of noticed when we were planning this test of change, and this is what we wanted to try and make better and to make more efficient. In terms of waiting waste, that was the main thing that we wanted to combat. However, we did have a lot of human error and information bleed, for want of a better term, i.e. things would go wrong, miscommunications would happen, and sometimes the wrong information would end up being written down on a sheet of paper somewhere. Linking to the 7 Cs, we wanted to make sure that we're using our resources and digital systems to their full potential and reduce our wait for patients. Next slide, please. In terms of actions, it means that we, for me, one of the most important things was to not front load work onto the nurse in charge. So we wanted to try and reduce that nursing workload as opposed to add to that nursing workload. I didn't want to kind of change processes in a way which would be unsustainable. I wanted to do it in a way which would be kind of efficient and also try to sell it to the team in terms of this will improve their day and improve their kind of time in terms of getting that information across. As you'd expect in the Leeds Improvement Method, we did a nice production flow board, process flow chart, and we had that vehicle of information on that pink post-it note, all accumulating in the same spot, getting that information across. Massively inefficient, and we didn't like that. Back to the 7 Cs, in terms of using systems we already have, we had a few discussions about things which we could use. We ended up settling on Microsoft 365. It's a resource that the trust already pays for. Everyone has an account linked to your email address, and it's fairly accessible. And in terms of using the current processes, we didn't want to change those too much and kind of jolt the system too much. We wanted that sheet to just go from being on paper to being on a live document updated by the nurse in charge in the same way, just digital. Next slide, please. You can see our live document here, screenshotted a number of months ago now. This change was implemented in late September, early October, and it's been going ever since. You can see the nurse in charge updating the sheet. You can see it's nice and simple and doesn't change in terms of that paper chart. And you can also see a few of Mashid's team lurking in the corner there, ready for those updates. The initial aim was to reduce that nursing time waste. However, we do have some unintended results as well. So the bed managers were able to, for example, just note when the MDT started. Presumably that would be a phone call before as well, and the MDT in terms of completing that capacity report, completing the DOP report. So again, we'd have so much time wasting just on the phones. Has the MDT started so I can update the report or not? So it's an unintended benefits as well as having the previous day. So I can now look back for both J27 and J28 until September, October, and look at all of those changes for audit purposes. Next slide, please. In terms of engaging the team, I have spoken about this already, but we used our Kotter's steps for change. the main barriers which we had was digital confidence. I'm sure many of the people on this call have all been guilty of speaking when you're muted, when you're not thinking about it. I'm sure there's some people on the call who really take to digital systems and some people who do prefer that pen and paper approach. It was really important that after we created that sense of urgency in terms of getting the nursing teams to be on board and getting them to appreciate that this would save them time, we also then took a one-to-one approach for those who were less digitally confident and maybe needed a bit more time to navigate that Excel spreadsheet. We had the matron and PFC team on board, which was really vital, and we did start with just the one ward in J27 before, after the 4-week period, expanding that to J28. Next slide, please. In terms of an outcome, we used a survey, in terms of anonymous survey, that is, to get some results. We expanded that to not just the nursing team, but to other stakeholders, the matron and PFC being the obvious candidates in terms of who this would affect first and foremost. We compared their experience before using this tool and after using this tool. And we did some other things. For example, we did some unit monitoring beforehand to measure how long that took. Overall, we had a kind of time saving for all 3 individuals of about 10 minutes per day. Now, 10 minutes per day doesn't sound like an awful lot, but for 3 people, typically who have a nurse in charge, a bed manager and matron, 3 fairly busy people, that really started to add up over time, and you could feel the effects of this efficiency. We got that feedback from the nurses, the PFC team and the matron, and then we rolled it out on J28 as well, with some feedback from all of those individuals, and then we again sent that same survey out on Microsoft Forms to gather that data again. Just to add to that data pool from both areas. We also took some changes, some recommendations, both good and bad, and we implemented those or didn't as appropriate. Next slide, please. What went well? I think I tried to make it as easy as possible to use, recognizing that digital confidence and that issue. We had regular check-ins with staff. We built some good alliances, I think, with different stakeholders and tried to integrate this into the Making Every Day Count RPIW, which was happening towards the end of last year, which tends to help and got more people on board. Any issues were kind of escalated to myself in good time before I started to take more of a step back and sort of monitoring it less and less. And these days I don't see it very much unless I'm myself a nurse in charge. We also had regular opportunities for some feedback and improvements. And again, that was embedded appropriately. So, for example, we were aware and wary, I should say, of making this PPM2. We didn't want this to be updated every single minute of every single day, just to utilize that process we used to have and improve it in terms of efficiency measures. I always joke to people that this is a nice boring approach, but hopefully it would deliver some real efficiency measures throughout the trust. And my understanding is that it's since been picked up by some other CSUs as well. Next slide. In terms of doing things differently, we just used the one ward at the time. I think this was the right thing to do when we first approached it. However, if I were to replicate this in other CSUs, I'd probably do it with the whole of that area. I think it just means that you don't have 2 different systems going in parallel at the same time. And for the PFC team, I think it was slightly bizarre to have 2 different wards effectively doing the same thing on 2 different systems. My key learning is always that it's possible to talk less whilst having efficient transfer of information. I think we're quite eager in the NHS to pick up the phone and speak to people. And actually, whilst that's really nice and very personable, it's not always the easiest way to get that information across. In terms of next steps, we're continually tweaking and optimizing it. We're now using it to audit how long an MDT takes, when it starts, when it ends, the issues that transpire within it, and then looking at whether we can reduce our paper workload as well in terms of giving that to staff. I believe that's the last slide I have, so I'm happy to take questions now, or would it be at the end, Tasha?
We'll save them for the end. I'm sure people will have many. That was such a fantastic presentation about balancing the tools with the people. So I'm sure people have got lots of questions for you. But we'll hand over to our next presentation. Rashid and Bogdan, are you? Oh, I can see you there. Brilliant. Are you ready to go?
Yeah, for sure. Hello,
Brilliant.
all. My name is Bogdan Onel. I'm one of the patient services coordinators in SIM. And today we, along with Mashid, we've got together platinum transfer to medical fit for discharge wards and golden discharges before 10 o'clock. So our challenge always in every CSU, we've got problems with late discharges leading to delays in patient flow. Myself, I'm working for the patient flow team as well, as long as Mashid as our matron. We had the main problem, overflow in the admissions wards in ED due to delayed transfer and long waits for the beds. We've been working in link with the 7 commitments, working towards reducing waits for our patients. Next slide, please. And our actions, so we introduced the golden patient discharge. A golden patient discharge is a patient medical fit for discharge, ready to be discharged before 10 a.m. So this discharge can be either discharge from the ward directly, or it can go to the discharge lounge pending transport, EDANs, family collection, etc. And as a result of that, we introduced the platinum patient transfer. So patients who prior with 24 hours, we are identifying them, patients who are fit to fill those beds across. So if we are talking about Beckett wing, for example, we are finding patients suitable to go to fill those patients to golden discharges from Beckett wing. Either if the patient's in a bay, side room, enhanced, non-enhanced. So we are looking with 24 hours ahead, and we are trying to identify suitable patients to go across over there. We've been working towards the Leeds Way value, focusing to deliver the high quality, safe and dignified care. We commitment to the early discharges and using the capacity effectively. We saw an increased rapid on patient transfers and much more effective communications between the wards and our patient flow team. And we identify the patients 24 hours before the transfer, the platinum patient transfer. What worked well? Communications between the wards, and patient flow team, it's working, it's improving, and we identified along with the wards suitable patients to go across over there. Though we've done that by attending to the safety huddles and MDTs. We discussed it with our colleagues, and from the staff feedback, it was quite good actually. Next slide, please. So this is our data. It's only SIM, what patients went from our wards to the discharge lounge, and the next slide will be for the patients who went across to those golden discharges though. So you'll see individually through each ward from November, December and January, how many patients we had who they've been discharged before 10 o'clock, plus a golden discharge. Either, as I said earlier, they went home from the ward, or they went from discharge lounge before 10 o'clock. Next slide, please. This will be the platinum transfers, the beds who they're being refilled by the patients from our bed base going across to different areas in our empty beds. And I'll pass the next slide to Mashid, if that's all right.
So the purpose of our using a golden discharge and platinum transfers was about we recognize majority of our discharges is from our medically fit discharge wards, and we could not use those capacity on time. So as everybody knows, patients when they attend the A&E, they need to transfer to the admission wards. In order to create admission wards, we need to move patients from admission wards to the base ward, and then from base ward to the Beckett wing, to the medical wards. So what we recognized is we do not use these capacity on time. So those beds stayed empty for more than 3 or 4 hours. So in order to reduce these waiting times and bring the patients sooner and create that capacity in our admission floor, we recognized we have to use these beds sooner. And that is why the purpose of the identifying the golden discharge and then the transfer patients suitable for the Beckett wing was from the night before. So in the morning, we knew before 10 a.m., those capacities are going to be emptied, used, and the admission wards, they will have enough beds to bring the A&E patients. So the outcome for us was excellent, because we managed it to, particularly for the patients who've been in the A&E for more than 20 hours, when it comes to the morning, they have that blockage in the system would be easier, we could release it easier. And then that also has given a empowered the staff. They knew exactly what they have to do first thing in the morning. The purpose of the golden discharge was making sure the patients have the medication, have the all their medicines for going home ready, go to the discharge lounge or the transport. There wouldn't be any delays for waiting for the transport or anything else. Everything was ready for them to go. And then those beds getting cleaned on time for the next patient to come. Then we didn't have to wait and to say, now find out who's the suitable patients. Do we need to go and speak to a doctor? Do we need to speak to a nurse? Are they ready? So the next patient was already packed, ready, handed over from the other ward. So all the nurses, particularly the nurse in charge, they knew what's going to happen on that day in the morning before 10 o'clock. So everybody knew they have to create this capacity. And that was a biggest advantage for us, empowering our nurses, knowing their business, and also reducing the waiting times in ED. Can we go to the next slide, please? So as I said, it was a better experience for the patients because one patient, they knew they're going home. They don't have any delays. Two, patients knew they're going to the Beckett wing to another area, so it wouldn't be a shock for them. They were ready. And three, patients in ED knew they're going to have a bed in which area, so they knew already that. And I'm very grateful. Everybody were committed, all the matrons, all the junior staff, the senior staff, everybody were really dedicated in these transfers because they knew it has a major effect on their workload and it has a major effect on the patient safety and the quality of the care. And obviously, it has affected massively on the staff morale. Next, please. So what we do different next time is what we recognized in Beckett Wing, because they are a specific area for the patients who are medically well. We have areas which they are an enhanced space and a non-enhanced space. And identifying a suitable patients for these area, it was important. And not all the time we knew which area in those wards are an enhanced space. For example, if a bed 13 in J32 was going home, we do not have those information. We had to still make a lot of a call because we cannot just map the ward and they say from bed 1 to 13 it has to be enhanced. Everything, it goes on a daily basis, the changes. So we have to think differently about creating a map or having a better knowledge of these areas. And the key learning is again providing that early information for patient flow. If we do not have those information, who's the golden discharge, who's the next patient can use that bed, is they are the important information, vital information for the patient flow in order to act on their they take any actions. And the next steps for our improvement, probably one of the things we always suffer, the lines constantly engaged. We did introduce this to having a portable phones for the nurse in charge to have it in their hands, but unfortunately the technology wasn't very good. So we're hoping to have a better technical, I don't know, the better mobile phones or better signals, so the nurse in charge always have something in their hand so they don't have to call specifically to the ward. That phone is only for the nurse in charge for the important and urgent information. The next stage, sorry, slide please. And that's it. That's where we are. Yeah. If you have any question, please do.
Brilliant.
Thank you.
That was fabulous. What a great thing to think about. Not just the patients that we have now, but that next patient as well, that real balance of patient safety. I'm going to open it up to questions and comments from everybody else. And I can't see anyone for the moment. Is there any? We've got a hand up from Paul.
Hi everyone. Paul Jones, Chief Digital Information Officer. You may not have this information, but just looking at that last one, it's great to see that focus on early discharge. Great to see that focus on patient flow. But from the numbers, couldn't quite see how you were improving the situation, because we just had the absolute numbers. So couldn't see whether it was all the patients were being done or whether half the patients were being done. I can see Ian there kind of reaching over. So I don't know if you've got any idea, Ian, about how, was that improved? Because the numbers look the same, but no idea how many discharges there were. So that just interested to see whether it was having an impact. Yeah.
Hi, can you hear me, Paul?
Yeah, got you. Yeah.
Hi, Paul. I thought it was an excellent 2 presentations, both of them great, and really enjoyed the one from Bogdan and Mashid in particular, representing some of the work we're doing in SIM. In response to your question, Paul, so what SIM's seen in terms of the step change, so this was an initiative that was born out of the Making Everyday Count work that Mashid and Bogdan had developed with colleagues. And what we've seen since then is our discharges by 12, so that's the metric we work to, has had a statistically significant step improvement. So we're now seeing around 30% of our patients being discharged before 12, and now over 50% of patients being discharged before 3. So it has had a real impact. And I think what Mashid and Bogdan are highlighting here is this is the very first step in the daily flow for us now. So before, we were having to have a series of meetings and identifying patients, and it would all be done on the day, at the start of the day, and there was a bit of a kind of a revving up the machine towards that. What the team are now entering into first thing in the morning is the knowledge of the first few moves they're going to do. They can already enact straight away because they've been pre-planned from the day before, and that is happening for at least 2 patients every single morning. And it might sound small numbers, but actually it's bringing those first few forward by an hour or 2 lets us bring the next few forward, and the whole thing is shifting to earlier in the day. So it is having a demonstrable impact.
Brilliant. Thanks, Ian, and yeah, thanks to the team. Great bit of work.
Wow, and we've got a comment from Magnus as well about that significant change. That is a massive change, and some of those graphs really do show that. Any more in terms of comments and questions for the presenters today? No, fabulous. Well, they were both great. What a way to end the week, especially when we're under such operational pressure. That was brilliant. Thank you very much, and hopefully we'll see you all next week.
Thank you. Thank you.
Thank you.
Bye-bye.
Take care.
Thank you.
Bye.
Thank you.